Hi, welcome to TCTMD. My name is Mamas Mamas. I'm the Senior Clinical Editor and we're at India Live. And it's my absolute pleasure today to introduce my two guests, Professor Ashok Seth and Professor Shiba Chapra. So welcome to both of you.
Thank you.
Thank you very much, Mamas.
So the focus of this interview is going to be around STEMI care in India. And it's really interesting to hear about the expansion of primary PCI and tier 2, tier 3 systems. I mean, what Shiba, maybe I can turn to you. What do you see the main limitation in India of STEMI care to be?
STEMI care in India, there are a few limitations. And if you talk to me about the main limitation, I think awareness and patient realization of symptoms and, kind of turning to the hospital in time, and the delay that occurs at the level of not just the patient to identify the symptoms, but even the physician to pick up the symptoms and refer in time. So, but I think we've come a long way, and Dr. Ashok Seth has been one of the pioneers, and we have several programs for the STEMI networks, which brings the patient faster. And we believe that in an Indian setup as ours, even a pharmaco-invasive therapy, does quite well. The patients are thrombolyzed, put, sent to us, and then, PCI is done in the first 24 hours.
I mean, Ashok, do you see still inequality in access to STEMI care in India, and what is this inequality?
Oh, yes, I do. And before that, Mamas, we were talking about the growth of India Live in 3 meetings, should we say. 2020 was the last, and then we didn't have, and then we had one last year and this year. We've grown double. It's 2,700 attendees, which is double. That just shows the fact that our interventional cardiologists are increasing in numbers. But as regards equity of care, yes, a country like as big as us, with the socioeconomic divides that exist, is always going to have inequitable care. What's important for us to make sure that while they may have access is getting more important, availability and understanding, we got to convey downstream as to what's needed from them. Now, that's true that some of our patients may not even get to a healthcare facility which would even lice them in enough period of time. On the other hand, because we are multiplying cath labs in tier 2, tier 3 cities, and for the first time, can you believe that we would be perhaps equating USA in the number of PCI procedures being done? And majority of these, 60 to 70% of these are ACS patients, because that's the one who lands up at the door and is going to land up rather than chronic stable angina. We are encouraging people to understand, firstly, that if they go to a lytic center, they have lytic, but we are also encouraging the physicians to start understanding that they have to be referred to a center which could actually do invasive procedures. Yes. So that's the first thing. So first education point is definitely even the primary physician in a small city. And the second point of education is the patient himself, who needs to realize that he's got to get to the nearest hospital as fast as possible. And whatever treatment is offered, he has them. There's a lot of skepticism in a common patient about when we say, oh, you need a angioplasty straight away, you need a PCI straight away. And he says, I just had a pain, I was fine 2 hours ago, and now they want to shove me into a cath lab and make me spend. We must remember that healthcare is private to 70% of these patients, 80% of these patients. They are pay out of their pockets. The moment infarction happens, they are told to pay out of their pockets for the treatment. And if the treatment is something like a PCI, it's far more expensive than lytic therapy. Yeah. So yes, the care is unequitable. The care is different. But on the other hand, yes, we don't have a system which pays for them. And therefore, education becomes important in them accepting that the treatment they're having is worth their every penny at that particular moment.
Yeah. So maybe I'll ask my first question to Ashok again and then to you, Shiba. You've talked about the growth of primary PCI services and the growth of cath labs. How do you assess for quality and how do you monitor quality of service being delivered for your STEMI care in India?
A great question. And can it be uniform all across the board? Because we're talking about public hospitals, we're talking about small district general hospitals. And by the way, in our district general hospital means really remote areas. We are talking about private hospitals, which provide 70% of the care, especially if we talk about STEMI. Every hospital which is private, and most of our major university public hospitals, do believe a door to balloon time if they are interventional, if they are a PCI center, and most of them are. As we multiplying our young gen interventional cardiologists at a pace, where we're covering a lot bigger areas now, maintain a door-to-balloon time. And believe you me, our door-to-balloon times are better than anywhere else in the world. And I'll tell you exactly why. In a private hospital, and even in there, and there's this university private hospital or university, they've created systems, and we created systems where we have 24 hours a consultant on call on site, not running from his home to do a primary PCR on site.
Yes.
We have a cath lab staff on site 24 hours. We got nurses on site. We got everything on site. So for us to provide the gap between him coming into the door and in the cath lab is none. In a private hospital like ours, it's just be saying it'll cost you X amount of money.
Yes.
You've just got to promise that you'll pay that money. And he says, oh, is my bank balance good enough? In their hospital, which is partially private and partially public, would actually just say, let's treat you straight away.
Yes.
And believe you me, she'll tell you her door-to-balloon times could be better than anything you've ever heard of.
Sure.
Because what's your
surely, sir. I think you're very right, and we've been experiencing it over the last so many years.
Yeah.
We just tell them that this is what's going to cost and what are the risks involved, and usually the patients consent. We don't ask them to pay at that point of
That's right,
time.
we
They
don't
get
ask
another 48 or 72 hours to do
pay.
that, and we just rush them into the lab.
So-
and our physicians and staff nurses are all ready for a primary.
So our 90% of our patients, the door-to-balloon time is less than 45 minutes.
Yes,
Yeah.
I mean, that's great. I mean, Shiva, you've done a lot of work and you're a big proponent in cardiovascular health in women. I mean, in terms of STEMI care for women in India, where do you think the missed opportunities are, or are there missed opportunities?
Oh, well, now you are asking something which is really very dear to my heart. And I do believe, that women receive less care when it comes to not just STEMI, but everything. But when we particularly talk of STEMI, of course, they realize their symptoms late, they reach their doctors late, they get less access to the treatments. Besides having very less representations and datas and trials, they are getting less invasive and aggressive treatments. Most of the times they would be managed medically, and their symptoms would not be realized not just by themselves but also their treating physicians. So less PCIs and less GP2Bs and less devices, less ICDs. But much more than that, if we actually get into the system, we have done a study at our center where we had around 32,000 patients who came for a routine cardiovascular health checkup, and we realized that for last 15 years the trends over the last 3 zones were that 70% of men were actually coming just for treatment.
Yeah.
Only 30% of them were women, and that also 42 to 50% were postmenopausal. Less premenopausal and very less perimenopausal were actually coming for the treatment. And in rural India, you see, where we have women who are just sitting by the chulas and smoking that kind of fumes that
Yes.
actually come in, and air pollution and the link with cardiovascular diseases is all the more in women. And if you ask me, I can't just stop saying that pregnancy related risk factors are abundant in women. We can't afford to miss that.
So I guess one of the things that India is very well known for internationally is innovation, technology. Ashok, how are changes maybe in digital health innovation changing STEMI care in India? I mean, has there been much of a growth in that arena?
Right. I'll address that in a moment, Mamas. One thing which came to me was that while we were talking about primary PCI and it being available, and most of the private centers being very proud of their door-to-balloon times, which are much lower than the West, there's also a group of people who's still getting streptokinase, you'd be surprised.
Yes.
And we shouldn't forget that aspect as well. And that could be a large population of patients in the small villages and small towns whose nearest center is perhaps a small government clinic who would give them streptokinase. And we've been trying to shift that to at least saying, if you're going to lyse, then it has to be TPAs and tenecteplase and so on and so forth, which are found to be far more effective than the streptokinase. And by the way, those drugs, which used to be expensive 10 years ago, are getting cheaper and cheaper because they're locally manufactured. Yeah. So clearly, reinforcing the government to shift its mind that if it's not going to be primary PCI, at least it's going to be the newer agents, lytics. So I think then we'd be doing favor. We've also been trying to create networks in certain states which are much more intellectually driven, much more. And by the way, healthcare is a state-wise issue. It's not a national. It's not centralized. So every state is responsible for its own healthcare. And there are certain states which have created tremendous STEMI networks where people from even villages, if they go to the primary center, get a drug given would be shifted to a district general hospital or even shipped to a cath lab facility subsequently. You asked about innovations, and
Yes.
It's been a tremendous part, right from tertiary to primary to secondary to primary. For example, EKGs. For example, transmitting EKGs. India's got the highest proportion of cell phones, as you know. There are more people in the world.
Yes.
Our network of Wi-Fi exists everywhere. So that's the great advantage. Even in the remotest parts of India, you can get a network. So cell phones and networks being common, EKG at a doorstep is not an unusual. Centralizing and creating a network is the more important aspect, because that's where the state government has to get involved. So that's one aspect. Even, for example, a primary PCI being done at a remote center can be actually monitored by me and advise exactly what he faces. It's a thrombus. How do we actually deal with that thrombus? And we have network connects for something like this. So that's, again, digital issue. Arrhythmias. We've created a system of remote ICU and CCU monitoring, which gets linked up, and that CritiNext is a centralized system where we developed it 10 years ago, but it now covers 1,500 CCUs and ICUs across the country in the remotest part, where we can actually monitor patients and their EKGs real time through centralized stations, which actually look at that and advise the doctor as to what the next step he can take. So innovations in healthcare are profound because IT is important out here and connectivity is great out here. What it has to do is the public-private partnership, which becomes more. So we have to go upstream. It's not just creating apps and innovation. We actually have to provide it. After that is the care downstream. And we have to build it up to a centralized healthcare system, which says that's what we want to deliver to our patients. So in isolation, we have loads of these activities happening, but as a process which is national, central government, funding, research, science, and its delivery downstream, be it private, be it public, has to link it all together into a single motto of ours, which is make sure that we can save lives uniformly across the country and not just for a few who can afford it.
Yes.
So with that vision, I'd like to thank you both for a very interesting and topical discussion. And I'd also like to thank our viewers at TCT MD. And finally, Ashok, again, congratulations for this meeting.
Oh,
It really
yeah,
is super.
Thank you,
Congratulations.
Mamas,
It's been
and thank you for
awesome.
being here. And it's wonderful talking to you
Yeah.
both. To you both.
Thank you. Thank you.